Good morning, good late morning to everybody here and everybody who is online watching as well. It's been such a busy and productive meeting so far, sort of learning from the fire hose, right? That analogy, lots of information. Thank you for being here today for this session. So my name is Yvette Bordelon. I'm a movement disorders neurologist who's at Cedars-Sinai in Los Angeles, most recently at UCLA. And I've been working in the Huntington's field for many, many years. Working in the lab back as a graduate student the year that the Huntington gene was first discovered. And I was just sharing with some of our friends in here as well to see the amount of progress that has been made in research over these years is simply incredible and really encouraging and very promising. With the session today, what we'll be covering and talking about in a little bit more detail is managing the changing care needs over time in Huntington's. This is not a one-size-fits-all answer to this question. And so what I'd like to do is kind of go over a series of checkpoints, pearls, suggestions, and ideas for helping everyone to navigate through their own journey. There's been a number of presentations that have already occurred yesterday and will be occurring later today that complement and support this information. And so it's really an honor to be here and present as part of this series today. There's a quick slide that is presented for all of the HDSA talks that we're just providing this information. And your real care is going to be with your team, right? With your primary care provider, neurologist, and other healthcare providers about any specifics to treatment. So these are overarching recommendations. My disclosures, I receive research funding from a few different companies as well as honoraria from Neurocrine in the past. So what I'd like to do is, this is what we want to establish, is that this is a continuing conversation, that you need to bring people into your support team so that you're having this continuing conversation over time about when it is time to change the caregiving needs and to bring in additional care and support to help care for your loved one. And so I'll present, first of all, starting out with an overview of HD symptoms and its impact on care needs, and then run through sort of the importance of recognizing in these time points from early stage symptoms through to more advanced stage symptoms, but recognizing that it's really a continuum of progression over time. There aren't specific points where it's, so now we're going into the mid stages. It's not that straightforward, and everyone is different in their continuum and their journey with Huntington disease. But again, there's certain features that we want people begin to discuss and think about when we're transitioning into higher level of need and higher care needs, of course, to support caregiving through all of this process. And so Huntington disease, again, is comprised of a triad of symptoms: motor, cognitive, and behavioral. Of the motor symptoms, and we still define symptomatic Huntington disease with the onset of clear movement problems, chorea being the most distinguishing of those movement problems. But we see a host of other movement issues that can present and be a part of someone's symptomatology. The cognitive issues are sometimes very subtle, particularly at the onset. Usually higher level executive function can be impacted early on. But we also see other memory and language difficulties as well as visuospatial problems too. And from the behavioral symptoms, another big component of the symptoms of Huntington disease, run the full gamut of behavioral symptoms: depression, anxiety, a lot of obsessive compulsive tendencies, and even more extreme or more problematic irritability or outbursts. But it's how these symptoms appear in an individual and how they change over time that impacts their overall function. And when we begin to see this functional impairment, again, beginning very in subtle ways from that combination of movement, mood, and thinking, that might affect your ability to maintain a current level of employment or to go to school. I'm going to talk about adult onset and juvenile onset sort of in the same context here, right? So in adult onset, it would be affecting level of employment and the ability to maintain that employment and job function versus performance at school and keeping up with school demands. as well as family participation and obligations, social activity, socialization, and even the basic activities of daily living. And what we've learned over time from the many observational studies that have been done, including Enroll and Track HD and Before Enroll cohort, and thank you to those folks who have been a part of those studies because so much has been learned from that information, is that we know that folks do not manifest symptoms for a period of time, right? There's a pre-symptomatic phase, and at some point in time, those symptoms begin. And if you were at the research meeting earlier, there may be some ideas for why that's happening, why there's specificity within certain neurons in the brain and why it happens later in life. But we do know that those motor symptoms, again, when we have that switch between pre-symptomatic to symptomatic, and those motor symptoms get worse over time. But what has been demonstrated that those cognitive symptoms that I talked about appear earlier, most often appear earlier than the motor symptoms. And the behavioral symptoms appear even way earlier than the cognitive symptoms. And again, it's when things begin and how things change over time is one thing, but it's how it affects an individual's function. And we usually begin to see this as the combination of symptoms occur and worsen over time that we see an increasing dependency on the need for help and support and increasing dependency on caregivers. From the HDSA caregiver guidebook, and I would encourage you to try to obtain that or look at it online and stuff too. It's a great resource, an amazing resource to help with this. But we've broken it down into some phases of Huntington's disease to think about, so early, middle, and late, based on those movement symptoms being very subtle or mild to the beginning to more advanced stages where we have significant difficulty controlling those movements, and how that might impact where care can be provided within the home or in higher level of care. And that's because of the impact on the activities of daily living and the inability to maintain employment or to go to school, and factoring in those emotional and cognitive symptoms as well. What I want to add to this is sort of another category, which is that pre-manifest, the pre-symptomatic phase. Recognizing that even though we are not defining folks as symptomatic until the movements appear, that folks in the pre-symptomatic phase have a significant impact on their activities of daily living function and performance too, because often they are in a HD family and have to are caregivers themselves. And the amount of emotional and emotional symptoms that go along with this must be factored in, right? Folks have to take time off or family leave to help with caregiving needs, as they are also dealing with their own diagnosis as well. So I want to include that into our thought of sort of the phases of disease. And I want to distinguish this from the staging system that has been developed and recently changed for clinical research in Huntington disease, because you'll hear a lot about this as well. And this is a more recent change, and it's the integrated staging system for HD used for research purposes, really highlighting that we are able to begin to see changes in the brain before any of the symptoms appear in HD. And so that staging system really begins just knowing that the gene mutation is present. And then we begin to see some biomarkers, but no symptoms yet. It's really stage 3 for this system where there's functional changes and we move through mild, moderate, and severe stages of Huntington's here. And as I already mentioned, right, we're going to break this up into categories, early, mid, and advanced, but really it's a continuum over time, and that care needs are really part of a continuum over time.
I just have a quick question. With that being known, do you think that people, when they're diagnosed with HD, should get an MRI of the brain so they have a comparison?
So that's a good question. So the question was, should you get an MRI with diagnosis? And that's going to be person dependent and practitioner dependent. I tend not to do that because the changes that are found on the studies are usually with specific quantitative methods that are used to detect the changes in volume of striatum and cortex. And you begin to see those changes early on. So unless you have that detailed scan as well as the interpretation to know, you're not going to be able to pull out those subtleties. But the most important reason is that it doesn't affect what we recommend or do from a decision point for treatment.
Yeah, I didn't know maybe if it was science, if the care in the brain is like in the phase where it's not.
Yeah.
Maybe a yearly one to kind of show if there's changes.
So that's a good question too. Should you do it because you would learn more by knowing the comparison before and with progression, and that's really particularly valuable in the context of a research study because those clinical scans are so different from machine to machine and place to place, and so the real value for that comes in the studies. A lot of the imaging is not included in Enroll, but for the clinical trials and treatment trials, it is. And so what's amazing, I think, is that if you're a participant in any of the clinical trials and biomarkers are collected, including MRIs, that information is used for future studies and helps to guide future studies. And it serves as a bank of sort of the untreated, a placebo arm even, right? So it is extremely valuable. But obtaining it clinically for one's care, it doesn't carry that same weight or value. But thank you for asking that. It's perfect. And so really emphasizing not only is this a continuum where we don't have these set cut points for progression from one stage to another, the other challenge is that no two people are alike with Huntington disease. Even knowing that this is a purely genetic disorder, we know the mutation, every individual is different in the symptoms that appear, when it appears, how things change, how they respond to medications, how people respond to different drugs, what side effects those drugs cause in an individual, and also the constellation of the combination of mood, motor, and cognitive symptoms. In addition to one's own lifetime experiences and other medical problems, right? So there's all the other things that happen too. COVID happened to all of us, right? And so there are other factors that will significantly impact one's own function and the care needs at that point in time for that particular individual. The other major challenge in trying to present this to you today is that resources for caregiving and support and for making this vary significantly by state, by city, by health system, and by each individual specific situation. Your own insurance coverage, your own other medical coverage and needs, finances, work-related issues, school-related issues, all of it is very individualized. And so what we often do, and what I will recommend over and over again during the session today, is building a support team to help you navigate the complexities and really having that support through the journey with Huntington disease. And what is the most important ingredient, I think, for this support team is social work. And so there's over 100 social workers at the meeting today. Each and every one of them, of course, have a passion and dedication to Huntington disease and helping patients and families. And they are critical to helping us all navigate the many, many challenges of this disease, and particularly with the care needs over time. But it's not just that, right? It's a complete support team of other healthcare providers and other community support and each other. One other important piece as a solution or a suggested solution for managing the changing care needs over time is planning and transparency. So discussing wishes early and often with the support network and all the ingredients of that support network so that it is part of the usual discussions and plans are made. There isn't any necessarily surprise. What is most difficult is when these changes need to be implemented in crisis mode, right? When something has happened, someone has ended up in the hospital because of the difficulties with managing the complexities of the care need, and then you need to take whatever options are available. And it still comes to that, and there are folks there to help you navigate that decision point too. But the more that we're talking about this over and over again, the more that it becomes you're part of the plan and part of the discussion. Communication is critical, it's key. And recognizing that the overall priority, right, is to maintain quality of life, and that means ensuring safety and care for the folks affected with Huntington disease, as well as the caregivers that are supporting, right? So again, anything that we can do to reduce the overload, that everyone is taking care of everyone within the family and all of the other obligations and stresses. It's been talked about in other sessions too. Isolation is not good in HD, right? We need to get out, communicate, share. You all being here is an important part of that sharing and communication. As far as planning and transparency, one of the resources out there that to suggest and to consider is something like 5 wishes. This is not specific to Huntington disease, but all care planning, particularly in the cancer world. And it just outlines these 5 wishes. Wish 1, the person I want to make care decisions for me when I can't, the kind of medical treatment I want or don't want, how comfortable I want to how I want to be, how I want people to treat me, and what I want my loved ones to know. So again, kind of incorporating this early and often, because this might change over time too, but to have these discussions, it makes decision points a little bit not easier, but they are a bit easier to navigate when they do come up, because you know that you've heard from each other about those wishes and what one would want. And including in this, as was mentioned in the research area, is brain donation. So those things that might be important throughout life and at the end of life as well. Important to document it, important to share it with healthcare providers and with your support system. Also taken from the HDSA Caregiver Handbook is the wheel of HD, recognizing that at the center is a person with HD and surrounded by a host of resources to help support them through this process, including friends, family, and others. But this support network and support system can change over time as well, and is comprised of a number of different pieces, each one sort of designed around your own wishes, needs, and particular situation, right? So there's family, that's at the core of that support. There's extended family, which includes the caregiving team at large as that begins to grow over time, teachers and aides for children who are affected with juvenile HD. They are extended family and part of the care and support. Friends and social support, this becomes critical. Spiritual and religious communities can provide inordinate amounts of help and support through this process. And again, not a one-size-fits-all. These are things that people find on their own and find what supports them in making these decisions and making these transitions. Support groups, they can be very helpful for folks, for certain folks. Other folks do not like support groups, or you try a support group not for Huntington disease, a different support group. I've had a lot of folks that have found inordinate amount of support and resources and friends and benefit from participating in AA, right? So it's not HD related, but it is a support network, it's a support system, and use what is available to help with this. Organizations such as HDSA and other organizations locally or in other disease organizations that can help. And then your healthcare system, really help use what is available through the healthcare system and the healthcare providers to help to support, and HD centers when they are available or close by. And what I'll use today is sort of this wheel of support and emphasize that those components, particularly the outer components, are going to change over time. Times when you need the neurologist, if we're making some changes in medications, when you need the psychologist, and you'll always need social work. Physical therapy may be another time, right? And HDSA, everyone who's here today or online today, HDSA is the bigger box right now. You're here learning, absorbing, and being proactive about really gleaning as much as possible. But I want to focus also on that inner circle, right? That inner circle is not going to change. That's you, friends, family, extended family. That part is critical, that part is core. And this outer rim is what changes over time. In thinking about this topic, social work is going to be top of the list. And again, they are the experts and able to really help guide and mold patients and families in navigating this road. Sorry, I'll go back. So thinking about very early stages and those early stage changes, what we see in the domains of employment or school is that there are subtle difficulties, again, coming from a combination of maybe movement issues, but also cognitive and behavioral changes. And so we begin to consider things like, are accommodations going to be helpful to help me maintain this level of employment? Are accommodations going to be necessary to help a child in school in that particular grade or plan? For the other family and social obligations, those commitments might be harder and more difficult to maintain. So do we have to adjust the responsibilities a little bit around this to avoid the stress or to avoid the difficulties that are happening, right? So if it's a lot of the housework issues, is there the possibility of having other folks come in to help with this or readjust the expectations for participation in those particular areas? Or some folks get very anxious about being part of a group or going out, right? Out to dinner can become an issue where people don't want to begin to withdraw and not participate because of the extra stress surrounding going out with friends. So do you make those gatherings smaller, or do you bring folks to you? What is going to be something that supports that inner circle and still allows you to enjoy the benefits of being able to gather with friends and family? And with activities of daily living, in the beginning, as these early stages evolve, we tend not to see so many significant problems, but we might begin to notice some difficulties and to really address this. So again, these mild motor, cognitive, and mood symptoms may begin to impact. You see a little bit of change. And this is when you begin to discuss options with your healthcare team, right? Are there medications that we can add or adjust? Do we incorporate physical therapy, occupational therapy, and counseling? Always. That's a consistent part of treatment and our treatment recommendations. And again, thinking about the social work resources that we can offer and engage in. And so I'll spend a minute talking just briefly about the symptomatic treatment, because as a neurologist, this is the piece that I do. For the movement issues for chorea, as Dr. Johnson mentioned, we now have 3 FDA-approved medications for Huntington disease. They are all different versions of the same medication, but we know that it does help with chorea. And what's more important is that it's on the FDA radar, that we need more therapies, we need more treatments, and so this should help to expedite future therapies for HD as well. And we know they all work really well for chorea control. But we also know that a host of other medications also help with chorea control, the dopamine receptor blockers, which are also known as antipsychotics, also known as neuroleptics. They've been around for a lot longer, and we use them often because they not only help the chorea and the hyperkinetic movements in Huntington disease, but they also help many of the behavioral symptoms as well, including irritability, anxiety, and psychosis, as well as obsessive compulsive traits. So we often use those medications to help address this. So again, in these early stages, as people begin to notice some of these symptoms cropping up, when you have your meeting with your healthcare team, we discuss these options. Should we start something? Should we not start something? And there are a host of other medications that we will consider, depending on how things change and how those movements and mood and cognitive issues are impacting an individual's quality of life and function. And as I mentioned, PT, OT, speech, those other services are a part of the recommendations throughout as well. In thinking about juvenile Huntington disease, we sometimes see slightly different phenotypes, slightly different symptoms. And they tend to have a little bit more dystonia or cramping of muscles, so we might use some of the medications that I list here for dystonia, just as an example. With cognitive and behavioral symptoms, we borrow from other areas. Anything that works for depression of any cause will work in Huntington's too. And so we use the full panoply of medications available depending on a person's need and tolerability and how those symptoms are affecting function. And similarly for cognitive issues, we borrow from the Alzheimer field because there are a few medications that we have available that might help a bit with memory and thinking in Huntington disease as well. When they've done the big studies to see if it helps in Huntington disease specifically, it hasn't been so successful, but in practice, we do know that we get some mild benefit, so we will use these in the right indication and if it is something that we feel is appropriate for a person and family. But really want to emphasize that, again, that the treatment has to be individualized. And we don't have many clinical trials, except the few that gave us the FDA-approved drugs, to say that this is the one path for treatment of HD. It's another area where it really has to be fine-tuned for an individual. But as part of the treatment, exercise. You'll see this over and over again at all of the sessions that you attend, and I can't overemphasize, we can't say it enough how important it is. And as you've heard of all of the benefits, the reason that we emphasize it so much is that it has the most evidence so far for a disease-modifying benefit in the brain, for Huntington disease as well as other neurodegenerative diseases. We know that exercise is a natural way of increasing growth factor release in the brain, something that is beneficial that will help keep neurons and circuits happy and healthy for a longer period of time. And these growth factors serve as beacons or sensors for the brain's own stem cell source around the ventricles to kind of migrate out. So it's a very powerful way to help to potentially slow disease progression. From what we've learned from the animal models, it's been shown that there's neuroprotection. We don't have that level of proof in the human brain, but this is the other reason that we emphasize the benefits of exercise, not to mention that it also helps from a behavioral perspective, those mood issues as well. And it's the best treatment that we have for walking and balance problems. The problem is that we don't have any specific recommendations for the type or the quantity of exercise. If you were at the physical therapy session in this room yesterday, there are some suggestions for combining weight training as well as balance exercise and aerobic exercise. But it's really about finding those activities that you will do and that you will do regularly. So there has to be some level of enjoyment and there has to be safety around it. But this is something that is really emphasized and incorporated as part of the care throughout the course of the disease.
Sorry, I have a question on that. I'm not sure if you said that there were not any studies yet with humans. I just have a comment to make. I was a caretaker for years.
That's great. So this was an amazingly powerful example of the benefits of exercise. And as you mentioned with your loved one, that the intense exercise, routine exercise, you guys saw benefit in motor symptom control. And that's what we want to harvest, we want to understand, and what we know so far is coming from animal model studies and stuff too. But again, and I think it's important once you get onto, because it's difficult to start, but once you get onto a good routine and a good pattern and you see the benefits, then that makes it even better, right? And more motivated to continue on. So that's a great example. So thank you for sharing. So the question is whether or not in folks with Huntington disease, would they benefit from other, or is it appropriate, Parkinson's disease exercises or other exercise routines like boxing? It all depends on safety. And I do use physical therapy and their expertise to determine, based on their assessment, what might be safe. But if they like boxing and it's safe to do, absolutely. Right? And it doesn't have to be a Parkinson's class. It could be a general class, particularly in early stages of disease. Other exercise classes, aerobics or otherwise, and not disease specific, are going to be very helpful too. And then again, in the early stages, he's thinking about some of the important social work resources, and I tried to list a few here. Again, there's so many differences and it changes so constantly. It's really good to establish a relationship with a social worker with your local center or through other care providers. HDSA has some information, and I clipped it here for finding a social worker, and there's many at the meeting today as well, because they can really help on several levels for this discussion, right? One is to identify local healthcare providers, because they're going to be in the know and they're going to be helping to navigate where are those neurologists, where are those primary care doctors, where are those physicians that are able to help with management of some of these medications or to refer out when needed. They're going to have the information and help you navigate the very complex, the very complicated world of accommodations for school and for work and for disabilities. And there's a session later this afternoon on disability that will be also helpful and directed, as well as insurance information. Again, complicated, very complex, very convoluted. And I work in California, and with Medi-Cal, which is California's equivalent of Medicaid, they change their rules all the time. And they will put people into different plans without them really knowing it. Well, they got a letter, it was 20 pages long, that said that if they didn't fill this out or send this in, they were going to put them in this plan. And they weren't able to negotiate that. All of a sudden, they're put into a plan where now they can't see any of their providers, or they don't have any access to their medications. It's awful. So social works help to navigate. They help all of us to keep on top of these things. And again, these are some of the resources to begin to pursue or to begin to investigate early on and throughout the course of managing with HD. I also want to bring up and thank those folks who are veterans and part of the military, so thank you for your service. But because of that, the VA has a lot of benefits. Talk about red tape and complexity. It's very difficult sometimes to negotiate that system, but in managing and helping to get through that, they have enormous amount of support and benefits that you deserve and that you would be eligible for. So try to take advantage of that health system as well. As the disease progresses, again, we see that impact from those symptoms that are impacting function a bit more, right? So more difficulties maintaining employment or keeping up with schoolwork. So we have to not only think about whether accommodations can be made, but considering whether or not we have to pull away from work and go out on disability. Or depending on the timing of things, is retirement possible? And this is something that's very different from person to person, depending on their previous employment. Does there need to be a change in school? Is the school not able to keep up with the needs of a child with juvenile HD? Do they have to withdraw? Are they going to be safer and better cared for with homeschooling? Yet there's all of the benefits that come from the socialization and being part of a classroom, right? So these are the complex thoughts and discussions that have to go around making these decisions, and where that inner circle is going to be helpful to help to manage and decide on these things, but also bouncing it off your sounding boards of the other folks in your sphere, right? Social workers, neurologists, your healthcare team, physical therapists, support groups are huge in being able to share that information. Also with family and social obligations, again, it becomes increasingly more difficult, so cutting back a little bit more, trying to preserve that if possible, particularly if someone really enjoys this. You want to, again, preserve that and make adjustments into the practice. And with activities of daily living, we begin to see more of an impact on that independence, and so more help is needed. And we may even consider equipment to help to do things safely and to begin to bring in durable medical equipment, or DME, and make home modifications to ensure safety as well. And this is when we pull in our physical therapists and that expertise, occupational therapy, to begin to say, hey, how can we keep the home safe? What other equipment, what other devices can we use to help keep things safe? And again, another checkpoint to see whether or not we need to make adjustments in medications based on the progression of those symptoms. Including, again, as I mentioned, PT, OT, speech, particularly when it comes to home safety evaluation. And then, is care able to be provided safely in the home? Is additional caregiver support necessary, or do we have to begin to consider possibly a move into assisted living? And what are some of those resources now? So again, going back to social work resources, in-home caregiving and assisted living, and it's very easy to mention, to think about these things and to do them. It is not straightforward, and there's not support to make this happen very easily. And this is one area where advocacy is extremely important at emphasizing the need to keep people safe and healthy and improve quality of life, and access to these services. And everyone makes a different decision about what is right for them with in-home caregiving versus moving into a facility and higher level of care. It all depends on that constellation of symptoms and then that inner circle as well as support system to make that decision. And ultimately, it does depend on the finances and availability. And again, there's a huge unmet need in this country, at least, for being able to provide that and access that. And HDSA is an organization that is advocating, and I know you were in a session yesterday, an advocate to for your loved one and for folks in your home state as well. And it's incredibly important because we are strapped with what we know is right, but can't necessarily implement or employ. But again, using this support system as best as possible to help to troubleshoot. Local resources, this is going to be, again, social work is able to help you navigate this, but word of mouth, support groups, other folks who have figured out ways of helping to manage. We learn so much from each other and from folks who are living this and have lived this, and to be able to share those hints, those recommendations are huge and really extraordinarily helpful. And there are different opportunities available. So in California, we have assisted living, but we have board and care. I learned yesterday that in Washington State it's called adult family homes. We call it boarding care in California. And again, it's going to be very different from state to state, city to city, what might be available for additional level of care. Looping in those therapists, again, PT and OT, for assessments for equipment and home safety, modifications that can help to make things safe. Speech therapy. Communication becomes an issue. So speech therapists not only help with speech and exercises with speech to maintain volume and clarity, but also other communication devices. Are there things that can be used to help to communicate needs? As well as swallow. So speech therapists are the same folks that assess swallow and safe swallow, and to loop them into the discussions as well. And as we see continued progression of Huntington disease, I spoke about the chorea, right? The defining motor symptom of symptomatic onset of Huntington disease, but we do know over time and with progression of disease that those movements become slower, stiffer, and folks aren't able to control movement as well. And so this is a different type of need and symptom to address from a medication standpoint, but from a care standpoint as well. And so at these more advanced stages, folks aren't able to participate in those not just social obligations, but employment or school, and become more and more dependent on care and full-time care. So again, that's increasing in-home care, transition to a facility if it is not able to be provided at home safely, and then also looping in additional providers at this point, perhaps neuropalliative care or eventually hospice, to consider these additional care needs. And this, again, is another checkpoint where you begin to pull in your team and discuss options with the healthcare support network too, including all of those ancillary services. And some of the resources here, again, thinking about social work resources that can be considered and can be helpful, especially, as I already mentioned, in navigating the in-home caregiver giving and skilled nursing options available for you and locally. And also with doing in-services. So in Los Angeles, we do not have a dedicated nursing home for our Huntington's disease patients. And some cities and some states are very fortunate in having a dedicated care facility. We do not have that. But the social workers in Los Angeles are happy to go out to any board and care, any of the skilled nursing facilities who have one of our folks and is caring for one of our folks, to do an in-service, to tell them about Huntington disease, right? It's a rare disorder. It's something that we are happy to educate the community about so that they are more comfortable with providing the care that is necessary. And I also want to mention again and I'll talk about it a little bit more, neuropalliative and hospice care too. These are additional tools and services where we have more resources and more expertise to help to manage in these later stages of life as well. And think about the durable medical equipment, DME, so medical equipment that can help us to support and care for loved ones in these later stages. And this is where, again, neuropalliative care and hospice care services can help to expedite that. If anyone has had to order a hospital bed, it can be an arduous process, but sometimes looping in some of these other resources, we're able to get it much faster. And so they're very instrumental in being able to do this. You'll see some of the vendors, and I have some of the pictures here of the Broda chair, for example. Extremely expensive. But if it's covered by insurance or can get covered by insurance, it's a great chair for certain people. So again, social work is critical. I'll mention this over and over again in helping to provide those resources and access to those services, and getting creative about the types of equipment that are helpful for an individual, specific individual with HD. So the additional chair there as an example. And going back to that continuum of care, as we just kind of ran through these stages, right, early, mid, and advanced, but emphasizing once again that it's a continuum and depends on what is happening in an individual's life and that inner circle that is so important for maintenance of care and support over time. And it's a disease that progresses very gradually over time. This is over years, right? And sometimes decades, particularly in adult onset disease. With juvenile Huntington disease, it tends to progress a bit faster than adult onset, but still over 15, 20, 25 years. And so it's important to really get in the habit of establishing these checkpoints where you're checking in with your healthcare team And these might be closer together at some points and they might be spread out. We like to follow our folks at least every year, and that's a minimum, because often we try to follow folks every 3 to 4 months, if not 6 months. And that's gonna, again, vary depending on the healthcare system you're in, where you are, and the other members of your support team that are helping to manage. But I think to get into the habit of establishing those checkpoints and run through the list of needs and updates on things is very important as well. There are sometimes in certain visits, or it's at the time of the visit, when I'm asking about, oh, have there been any falls, when all of a sudden, oh yeah, I fell a couple of weeks ago. And the family member looks over and says, well, you didn't tell me that. So we learn about it in the office together, right? And it's happened again and again, and that's okay, right? That's the safe space, that's where it's supposed to happen. And that's where we want to have that information and then troubleshoot around it. Where was the fall? How can we prevent that from happening again, right? Was it because the caregiver was not present? What were those things? And we can begin to help to bring in those resources and address those issues over time. So having those checkpoints, and if it's in the neurologist's office, that's fine. If it's with the inner circle and that support team, your support network, or if it's that support group, but just to have a set time to talk about where we are with things, how are we doing, everybody, right? The person with Huntington disease and the support network. How are we doing? Are we healthy? Are we happy? Are we able to do this and sustain this as we are now? Or do we need to make some changes? And then looping in that support network to help make those changes so that, again, we're maintaining safety and quality of life throughout, and really kind of focusing on that needs assessment at specific checkpoints. And thinking about some of the really important touch points and issues when we begin to consider transitioning care. From a motoric standpoint, it's with that worsening immobility, right? Greater fall risk or cognitive impairment, where there are more difficulties in managing independence and requiring more and more support, close supervision, and hands-on care. And those are real indications for the need for additional care support. And it's really difficult to begin to have those changes and acknowledge that I do need help and I need that support to maintain safety. And then sometimes some of those mood issues kick in too, right? So there's a lot of some irritability, there's stubbornness, that obsessive compulsive trait. That is what makes people so strong and accomplished and successful, but at times it makes it very difficult to care for them, right? Because they can be resistant sometimes. And so it's navigating that complexity as well and acknowledging that, yes, maybe we can't do things the way we have been able to do, but what can we do to make them safer, right? Exercise. We can't, do the exercise that we did when we were 20 years old, but how can we still keep up with movement in a way that you enjoy and that keeps you safe and reduces some of the complications from later stage disease? And accepting those modifications is difficult, but it's part of a process. And again, the more that we have the discussion over time and loop in additional people and support to do this, I always say that I'm happy to be the bad guy that says that, if you can't, driving is a big one, right? So if driving is no longer safe, then blame it on me, right? The doctor said this is not possible, or the doctor said this, and I'm happy to be the bad guy. But it's day to day that we need to, again, pull in those resources and that support team to help maintain safety and quality of life throughout the process. Open communication. And again, any available resources that can be tapped into, social work, the magicians of this field that are really able to help you navigate and pull things out as best as possible. And in thinking about the advanced stages, I want to spend a little bit more time in discussing neuropalliative care and hospice care. And hospice care is something that is, of course, is appropriate at the terminal stages of any disease, including Huntington disease. And we have a discussion over time really emphasizing that this is not a time where we are giving up. Hospice brings in additional resources to help you maintain quality of life through the end stages of life. And it does provide a significant support through this time. And really pulling them in early is helpful, again, for the family and for the person to live comfortably in these later stages. But what is recognized now, and more services have this, is neuropalliative care. So at a time where we're not quite ready to make that transition to hospice, palliative care, and specifically neuropalliative care, can be a great option as well. And so this is a little chart which kind of breaks down the difference roughly as you're on this path. And I've found that by referring folks into neuropalliative care, palliative care, it's very helpful because it helps with that discussion and that decision to transition to hospice care as well. So with palliative care, we get a lot of the resources and ideas for how to manage later stage disease. But it is still we're still at a stage where we want to treat things as best as possible. So if there is an aspiration event, an aspiration pneumonia, we treat it with antibiotics. If there's a urinary tract infection, we treat it. So we're still treating all of the medical conditions and all of the other complications that happen. But as the disease progresses, there will be a point where we have to make that decision that we are going to let nature take its course, that we are going to go through with these later stages of life. And hospice is then a transition where we make sure that folks are comfortable through those last stages, and then we make that transition to hospice care. And so I think it's really been helpful to have palliative care as an option through many different services now that help with this later stage disease before we're ready to move on to hospice care. And again, this is something that's going to really vary by health system. It's going to vary by location, state, and city. But something I think that I would start asking about as well. And I've, again, have found significant benefit for a lot of our folks and families over time. Importantly, supporting that inner circle, the caregiver circle, right? So family, extended family, all of those folks that are instrumental for providing that care day to day, and the extraordinary amount of work that goes into this and the stress that goes along with it. Self-care is crucial, and it's very easy to say, but very hard to implement. Again, just by beginning to have these conversations and discussions openly, early, and often, and to really begin to practice asking for other folks to contribute early and often, even if it's getting one of the kids to make dinner that night or to clear the dishes when they're not supposed to, when they usually don't, right? But get used to kind of asking for contributions, and support is going to be helpful as well. And same thing for resources, and start inquiring early and have those discussions with the healthcare team, with social workers. I don't need this now, but what about down the line? I'm thinking this, I'm thinking XYZ, so that there's sort of an overarching plan, so nothing is a surprise about when we're going to make these transition or these additions. And again, it's a discussion and a checkpoint that's had over time. I wish we could erase guilt completely from caregivers' plates and family plates. It's not possible to do. I wish I could do it. And it is a part of, I hear it in so many discussions. You know, I'm not doing enough. If I do this, it means that I'm giving up. No, everything that you're doing on a daily basis, day in and day out, is supportive. And partnering with that inner circle and recognizing, again, to try to avoid isolation as best as possible and realize that you need not just you, right, but the whole circle, as well as the extended circle with all of the support group and organizations, is extremely helpful in helping to manage and navigate this journey. And importantly, the advocacy as well. So whenever possible, to serve as an advocate, the more that Huntington's is out there and people know about it, the more that we'll get the attention of the federal regulators, FDA, for example, politicians who unfortunately hold the purse strings and make decisions for all of us, that, again, we need to get it to their plate as well. And so the more that each of us contributes when we can, there are going to be those times where it's every day and every minute is spent on your loved one, and in those crisis moments and in those moments, and then coming back when there's an opportunity to help with this is really a benefit as well. So I want to spend the last just minute talking about, again, that continuum and the checkpoints, and really driving home the importance to establish those routine checkpoints over time with your healthcare team, with the support networks, and importantly, with your inner circle. And at those checkpoints, it's a discussion about, are we safe? Are we maintaining quality of life as best as possible? What is our planning update? Do we still foresee XYZ in our future? Or no, I've changed my mind. I don't want this, I want that. And then a needs assessment. How can we make the home safer? Do we need more equipment? Do we need more activities? Do we need more physical therapy or exercise? The answer to that is always yes. Insurance companies limit how much physical therapy we can provide, but we try to get crafty in trying to ensure that that's still provided as well. And recognize that all of us and everyone in your inner circle and outer circle really have a shared commitment to providing compassionate and comprehensive care for everyone with HD and the families dealing with HD and throughout that journey. So we have a couple minutes for a couple more questions, and I'll leave this with the HDSA resources link and stuff there as well. But thank you for being here. Do we have any questions? Yes.
When you're talking about equipment and that kind of thing, when someone is starting to have trouble with balance and is walking very slowly and lifting their feet a lot, do they usually then recommend a walker, or does that get in the way?
Very good question. So the question is about how do you handle gait changes when walking changes? Is it automatically that you go from walking independently to a cane to a walker to a wheelchair? And for Huntington disease, that is not the case, because sometimes walkers do get in the way with those movements, and canes sometimes become weapons. So this is when people get upset and they don't help as much with the type of gait that happens, because it is very different than what we see, for example, in Parkinson's. And so then I usually rely on physical therapy and their expertise and their impression of the gait and what type of assistive device is going to be appropriate and helpful for that individual. And sometimes the gait looks extremely unsteady, yet people are okay. And having a cane becomes more confusing because, which hand do I hold it in? How do I use it? And those cognitive symptoms impair the benefit of the assist device more than anything else. And similarly for a walker, right? It gets in the way if there is some ataxia, and the chorea kind of brings your center of balance and center of gravity, you tip over, right? So it isn't sort of a progression of that equipment. It really, again, has to be individualized. And I've had folks that, again, the chorea is one thing, but I've had folks that have looked like they've had a stroke, that one side is so impaired. And that's not usual in Huntington's, but it's part of the Huntington's. And in fact, that person also told me that that's the way their dad walked with Huntington's too. In that situation, sometimes a cane helps, right? Because it makes you focus on that leg that's dragging behind. And so in certain situations, they help, and in certain situations they don't, which again, it's a complicated answer, but one that it's not a one size fits all. Thank you for that question. Okay, good. Oh yeah. Thank you for that. Thank you for that. So for people online, that was from social work that says use social work. Again, another endorsement. It's a free service, but also emphasizing the benefits of hospice early, again, and talking about it, because there are resources that are free that you can use and implement, and it's not something where you have to stay in hospice all the time. You can come out, and I've had folks come out for, say, Botox injections, and then a couple weeks later go back in, right? Because their hospice won't cover Botox, even though it does help sometimes with preventing complications. Anyway, you can't argue with insurance all of the time. So thank you for that. That's very helpful. I have the person in the back first. Yeah. Yes.
So I have a question about hours.
Yes. Right. So the question is about number of hours, because when you ask for respite or when you ask for caregiver support, they'll calculate out, and that number of 19 hours per week doesn't really cover. Actually, you need someone with you all the time to prevent you from doing dangerous things and to prevent. Yeah. I know. And this is what I always do too. I always ask for a lot, and then they give us a portion. And this is where, again, social work comes into play, to be able to say, what are other supplements to what you've been given? Or what do we need to say to say that we can increase the number of hours too, because we recognize that that's the case. It's never a matchup with what the needs are. And so it's a back and forth. And again, this is where it really depends. It changes from the resources available locally and otherwise too. In California, oh yeah, sorry. And how to maintain safety within the home. So creative safety, so document too, because when you have documentation, and that's video connection or video documentation too, to help to advocate for more time, but also to keep your loved one safe in the home, and ways of communicating with that too. Thank you for that. Yeah. Yeah, so social work advice, document the worst case scenario, worst case, right? And we want to say that, and I often, when I have to document anything, I warn people too. I said, I'm gonna make this sound worse than what I believe or what I feel for you right now, but I have to say what is the worst case scenario, right? And this is one way to document, because it's someone who's making decisions that just needs to check a box. So we need to get them to check that box. We have to stop? Okay, sorry, all right, we have to stop. But thank you guys very much for your attention, and then there's free lunch. Thank you.